Hi, this is Dr. AYYAPPAN V NAIR, and today I would like to discuss what is a kind of surgery to be done in shoulder dislocation. Is it the same surgery for all the patients, or does the surgery differ from patient to patient? Or the next question would be like, do all patients have to be operated? So I would start with the last question, that do all patients of shoulder dislocations have to be operated? So there are certain criteria for operating shoulder dislocation patients. For example, if the patient is a first-time dislocator and if he is not an athlete, we can always treat him by conservative management, that is, immobilize him for a few days, followed by, that is, we can put him on a shoulder immobilizer in certain positions depending upon the type of shoulder dislocation, the side root of shoulder dislocation, and then sending for physiotherapy. The question would be like, if he is a multiple shoulder dislocator, or if he is an athlete with a first-time shoulder dislocation, then he is to be operated on. So if he don't, then he would be ending up in several dislocations, and would really affect his shoulder, and the shoulder would become really very unstable. So coming to the next question would be like, what kind of surgery can we do for shoulder dislocation? Depends upon something called as the bone loss, and secondly on something called as what is the requirement of the patient. If he is an athlete, a contact athlete, if he is a professional athlete, and these are the questions to keep in mind when we take a decision. So if the patient is a multiple shoulder dislocator, that means, see, when the shoulder dislocates, this is the ball and the socket. It's called as the head and the glenoid. The head is the ball part, this part, and the bony part of the socket is called as the glenoid. So now, whenever we have a dislocation, that's the ball socket here, the ball rotates outside and comes out of the socket. So when it comes out of the socket like this, it also goes back and falls on top or in front of the socket again. So this results in a collision between the ball and socket, between the glenoid and the head of the humerus. So now this comes out and this comes and collides like this, like in this picture. Here, what we can see is, this is the socket. The socket, the normal shape of the socket is called as a pear shape. So you can see there's a pear shape, that it is more wider in the lower portion and narrower in the upper portion. So now, when the shoulder dislocates, the ball comes out, it comes and collides again, and when it collides, there could be a denting damage on the side of this socket. So normally the socket is a pear shape. So when we have this collision, there would be denting. And this denting causes a bone loss. And bone loss is gradually converting a pear shape into an inverted pear shape, where you can see that the base of, that is the lower portion of the socket, becomes much narrower. So if the bone loss is significant, so what we do is we ask all these shoulder patients to do an MRI scan with a CT scan. And I personally use a method called as Dr. Sugaya's method of bone loss calculation, where I can calculate what is the amount of bone loss. Bone loss more than 15% for me is significant. If it is 15% or more, then any bankart, that is simple bankart surgery where I would do a ligament repair, will fail. If the bone loss is very insignificant, less than 15%, then I would do something called as a bankart repair surgery. It is an arthroscopic or keyhole procedure where I stitch the torn ligaments back. So if the bone loss is more than 15%, then I have to replace so much of bone so that the surface area comes back to normal. And this procedure is called as a latarjet procedure.